Hi friends, good morning. Um, actually, whenever I see a question paper after NEET or INI-CET, I usually tell my friends, okay, these examiners are actually psychopaths, okay, because the way they set the question paper, it's like an MD final year, MD psychiatry final year exam paper, okay. But this time, I was very happy because the questions that is like some say it is 5 and some say it is 6 in psychiatry, but the 5 questions that most of them repeated and recalled was 5 questions, and all those 5 questions are the questions that we have rehearsed multiple times in our classes, and both in online and offline. And that's also, it's not a question which is totally out of the box or something, which is most important and also interesting questions which a student should know from psychiatry. So, a quick recall on those questions. First and the foremost, the question that has been asked, I will not be able to frame the question as it would have been because it's all just a word say. So we'll just try to, the main content alone would be same. It's all about a 22 years old female who comes with a group of symptoms. Okay. In our workbook, I think you can see it in page number 71. Okay. A person comes and says that a person is having palpitation, breathlessness, uh, giddiness, and a feeling of impending doom. That would be the uh, symptoms that a patient will come, and the person comes on keeps on coming with the to the casualty. The patient says that he's having palpitation, breathlessness, sweating, and giddiness, and this is not just once; it has happened multiple times, and the person is evaluated fully, and the patient is found that is within normal limits. And the patient again comes after some 2 months or 3 months, and it happens multiple times. What would be the diagnosis? The thing is that the diagnosis was, the answer was actually panic attack, because the patient is having, the question was very clear. The patient was having a symptoms of palpitation, breathlessness, tremors, sweating, choking sensation, and feeling crazy, feeling of impending doom, feeling crazy. So these are the symptoms. Usually patients comes with casualty, and I usually tell in my class that students out of and if there are like 100 times this question on panic attack has been asked, 70 to 80% of the time it's just a clinical scenario. Okay, only like 20% of the time it will be a scenario where they will ask what is the treatment for panic attack. As you remember in class, I used to tell that the treatment of panic attack is paroxetine, alprazolam, which is a FDA approved drug. And sometimes they might ask you what are the organicity that you will rule out. A person is having a panic attack. What is the organicity that a person can expect out of during a panic attack? And the questions will be like an heart condition, where it will be heart attack, or a lung condition like an asthma, or a thyroid condition like an hypothyroidism. And very importantly, substance intoxications like cocaine. Most favorite question of examiners: cocaine intoxication. Other person present with panic attack, what is the substance intoxication which may present like panic attack? It's nothing but cocaine. So these are the questions that we usually expect, and most expected and most recalled in our classes. Person comes with a clinical scenario: a palpitation, breathlessness, sweating, giddiness, and feeling of impending doom. What is what is the likely cause, or what is a likely diagnosis? The answer is panic attack. And I think that one of the choices was panic attack. And I hope that everybody would have given it correctly. The second very interesting question and very important question that was asked was, it was a question on antipsychotics. Okay. It was a question on antipsychotics. As I've told you, pharmacology is like a favorite honeymoon spot for examiners from psychiatry, because they the moment they find difficult to sit through just think through a question, they just come up with psychopharmacology, because it's very easy, it's very close to the heart. Now this question is very, very interesting and very important. The question that we usually say in our workbook, we would have been seeing it on page number 231. It is the question on clozapine. I usually give in our lectures, I usually say that a person comes to a clinic, okay. The person is having psychotic symptoms. And the person is having psychotic symptoms, you start an antipsychotic. You name some antipsychotic. It's you name type an antipsychotic 1, okay. You just wait for nearly 6 to 8 weeks, that is 2 months, and you just wait for another 2 months for another, like for example, the patient comes in January and February, you give him an antipsychotic, imagine a chlorpromazine. The patient is not improving, then you find that the antipsychotic is failed, and then you again start another antipsychotic. In March and April, you have an antipsychotic. Imagine it's like haloperidol. Okay, so 2 antipsychotics have failed. Then you call a patient is called as TRS. TRS is nothing but treatment resistant schizophrenia. When 2 antipsychotics is failed, you call the patient as treatment resistant schizophrenia, and a patient with treatment resistant schizophrenia should be treated with a drug called as clozapine. That was a first clue for the question. A patient has failed 2 antipsychotic, then what is the drug that could have been given by the psychiatrist? And another nice clue what was given in the question was side effects. Okay, what are the common side effects of the drug? The common side effects of the drug is, I usually draw like this. The patient will have what is called as obesity. You will have metabolic syndrome, dyslipidemia, and very importantly, you will have constipation. And most notorious and very interesting thing is, what is this is called as sialorrhea. See, I usually tell it in my class that when I was in CMC Vellore, we used to go for ward rounds. When we go for ward rounds, when the students, when the head of the department does the round, in CMC Vellore, nearly like out of like 40 beds, nearly 35 patients will be treatment resistant schizophrenia who's having on clozapine. They will be newly start on clozapine, and all patients, every bed, when the head of the department asks, like, are you feeling okay? Is there any complaints that you want to have, you want to share with me? All patients will complain that who are on clozapine, that they are putting on too much of weight, they are having constipation, they are having sialorrhea. The sialorrhea is very notorious because when you just lie down on your bed, the front part of the pillow, or the front cover of the pillow cover, will be fully wet with saliva. Now, when these people are complaining this, when they are very much worried about and they complain about this, we residents will be happy, or we doctors will be very happy. It's because once you know that the person is putting on weight, when the person is complaining of constipation, when the person has started having sialorrhea, it means that the drugs ceiling effect has been is reaching the brain, which means that the patient is going to improve soon, or the patient is going to show improvement soon. If there are patients who really, you start on clozapine and they have no problem, they have no side effects, they don't have any complaints, and the patient just stands like that, no sir, everything is good, I don't have any problem with the drug, then it might be a nightmare, because these people might turn into a class. There is a separate class called as treatment refractory schizophrenia, who do not even respond to clozapine. But that's outside our discussion topic. But the two key clues that they have kept in the question, and this question I really like, because any person who's entering to NEET-PG, who's going to go into multiple branches like medicine, surgery, or OG, should know that like a person doesn't respond with one antipsychotic, there's another antipsychotic, and this antipsychotic has a magical response, because after two antipsychotics you don't have to feel that okay, two antipsychotics have failed, will this patient improve? There's a third antipsychotic, or that's called as a class called as treatment resistant schizophrenia, which is treated with clozapine. And yes, notoriously it has some side effects, and those side effects are sialorrhea, obesity, metabolic syndrome, and dyslipidemia. Apart from this, there is some notorious adverse life effects which I usually mention in class, which makes them, which why that's the reason why we don't choose it as a first line drug, mainly agranulocytosis, myocarditis, notorious to cause seizures, and palliatives. That's the reason why we always reserve the drug for, we'll just wait two antipsychotics. It can be risperidone or olanzapine, or olanzapine and quetiapine. Just wait two drugs, see whether the patient is improving. If the patient is not improving, then name the patient as TRS, treatment resistant schizophrenia, and then start with clozapine. Because why we have to be very much careful, or why we have to wait, is of the notorious adverse effects of agranulocytosis, myocarditis, seizures, and palliatilis, where we'll repeatedly do ECG, CBC to make sure that the adverse effects do not arise, or if it arises, we'll catch early. But from the question, it's the clue was sialorrhea, I think. The sialorrhea and the weight gain and metabolic syndrome like symptoms. The third question is that was asked was from the sexual psychiatry, where the question was on yes, this they've asked the question on premature ejaculation. Yes, premature ejaculation. So what happens is that the treatment for premature ejaculation, the premature ejaculation, again, it's two types, which I've told you. One is organic and another is psychogenic. If it is organic, you will go for a treatment called as dapagliflozin. Dapagliflozin is an SSRI used for treatment of premature ejaculation. Whereas when it is psychogenic, there comes a role of therapy or counseling, where we do two types of techniques. One is called as start and stop technique, which was given by James Seamans. And another technique that we have is called as a squeeze technique. Okay, this was a question in our exam. Now, what is this start and stop technique? Is like it's the name itself denotes, when you just start stimulating the genitals, and once when you are about to the time to ejaculate, when you know that you are going to ejaculate, you will stop. Okay. Then after some time, again, you start stimulating the genitals. When there is a urge of ejaculation, you will stop. Again, the same scenario continues, and thereby you delay the ejaculation. Squeeze technique is where the coronal ridge of the glands, you just give a squeeze. Okay, and that's called as a squeeze technique, which will prevent the ejaculation. Okay, now the problem with squeeze technique is that it's usually, I said that it now in start times, it like it needs a female partner, and the timing is very important, where if you miss it, naturally, like will not be able to use the technique very easily. Now that's the reason why we usually advise start and stop technique, but these two are the named techniques which everybody should know in the treatment of premature ejaculation. And I was not shocked to see this question, because I hope that any person who reads anything from sex psychiatry, I've told that read something about erectile dysfunction and the psychological treatment from it, premature ejaculation, pharmacological and psychological treatment. Then I would advise you to read about paraphilias and gender identity disorders. So I don't think that this should be a surprise when you see this in your exam. And I think it's a pretty well decent and expected question. Okay. The fourth question is a lovely question. The fourth question was on alcohol, the most common question that everybody would have got it right. The symptoms of Wernicke's encephalopathy or Wernicke's syndrome. And there are two group of students who come and say that, like, sir, they asked me about the triad of Wernicke's encephalopathy, and they asked what is the name. And some people say, what is a deficiency which causes Wernicke's encephalopathy? So both is not a new or a difficult thing. It's expected. So I've already told you, these alcoholic patients who don't take food, because like they don't take regular meals, so naturally when they're not taking even food, naturally they will miss on green leafy vegetables and nutritious foods. So basically they'll be going into thiamine deficiency. Thiamine is nothing but vitamin B1, and this thiamine deficiency will present as two syndromes. One is called as Wernicke's encephalopathy, and another is called as Korsakoff's psychosis. And Wernicke's encephalopathy is a age-old mnemonic, is a triad of GOA. G for global confusion, O is for ophthalmoplegia, A is for ataxia. So when you get any question that is from a person is having alcohol and the person is having global confusion, ophthalmoplegia, basically ophthalmoplegia is nothing but a cranial nerve palsy of which is going to supply the eye, and also the ataxia, then you need to go into Wernicke's encephalopathy. And the very important part is it is 100% reversible. And you rightly find out and you just give thiamine. So either your question is on deficiency, which deficiency causes Wernicke's encephalopathy, or the triad of this is called as what? I think it should not be, you should not be shocked. So that is most expected and most important that any person appearing for NEET should know. So Wernicke's encephalopathy is triad of GOA, global confusion, ophthalmoplegia, and ataxia, and it is 100% reversible with thiamine. Next, we have something called on Korsakoff psychosis. Korsakoff psychosis, just for completion's sake, is where a person in the first stage will be Wernicke's, and if it is not treated, then the patient will land up in Korsakoff psychosis, where the patient will have memory gaps. And to fill in the memory gaps, you will cook up stories, which is called as confabulation. Most notorious question, but this time they have not asked, is like, confabulation is characteristic feature of what disorder? Korsakoff psychosis. Or what do you mean by confabulation? It's nothing but filling of memory gaps. For example, if I'm in a class, taking a class now, like from 7 o'clock in the morning, but I don't have a memory of that. So somebody asked me, what did you do today morning 7 o'clock? What do I usually do? Like, sir, I was walking, sir, or I was doing jogging, sir. What I usually do at that time. So that is called as filling up of memory gaps. So what I usually do, I just take that and put it in the question that has been asked, like filling up. I usually do walking. So at 7 o'clock, so today also I should have done walking. But today I was taking a class, I would forget because there will be a memory gap. That is called as filling up of memory gaps. Yes, and that's called as confabulation. So totally they have told 5 questions. Sixth question was something on neurology and psychiatry related, so I think it will be handled by the medicine people. So the 5 questions, one is on panic attack, most expected. I would say 100 out of 100. I think everybody would have got it. And close-up pain, it's a very interesting question. I love that question personally. Squeeze technique, I think it's not a very difficult question. And Wernicke's encephalopathy, it's again, it would be 100 out of 100 for all the students to answer it. So I hope all of the topics also add similar type of, all of the subjects also add similar type of questions. I hope the examiners this time was in good mood. They have given you nice questions which you can easily answer. A person who has given a decent preparation might eat the fruit of success. So I think there is a good chance this time. So I hope all other subjects is also in the same side. So all the best. Thank you.